Sometimes we just want EM knowledge delivered fast.
Yeah, this is the Emergency Medicine Cases EM Quick Hits podcast.
And we're your hosts, Dr. Katie Lynn
and Dr. Anton Hellman. Let's go. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. Here's a new EM Cases offering, EMC². Emergency Medicine Cases, where Katie or I interview one of our esteemed EM colleagues about a case, of course with many details altered for privacy. It's my pleasure to have on the show one of my colleagues from way back. I'm not going to say how long back because it's a little bit embarrassing how long we've both been practicing emergency medicine.
Embrace your age, Anton.
Yeah. But she is a fantastic clinician and has mentored so many other clinicians. And she is going to give us a case of the month from Janus General. Go for it, Dr. Lazier.
Thanks, Anton. So here's the case. This is a 59-year-old male who has a history of hypertension and anxiety, who comes with fever for 10 days. Medications include candesartan and fluoxetine, and he's been on those medications for a long time. And really, he's experiencing anorexia, malaise, chills, but really not much else. The occasional headache, but no vomiting, no diarrhea, no cough, no sore throat, there is a bit of slight belly pain on the right upper quadrant, but not persistent, and he's not really that focused on it.
All right, so far we've got a 59-year-old guy with a history of hypertension, anxiety. He's on candesartan and fluoxetine, and he's had this fever for 10 days, and he's got maybe a bit of belly pain right upper quadrant. Is this a biliary infection? Does he have some other kind of infection? Does he have a serious bacterial infection? He's on fluoxetine. Could this be serotonin syndrome? There's a whole long differential here. One of the things that I like to do up front when I have someone that presents with a fever that's for that long that doesn't seem obvious where it is I ask them about risk factors for bad infections.
Absolutely, Anton.
I guess my first question would be, has he been traveling anywhere recently? Does he use IV drugs, sick contacts, a sexual history? In terms of his risk factors for bad infections?
Exactly. That's exactly what I asked. So he actually has a fairly quiet life, living in an apartment, hasn't traveled, isn't from an endemic country where he might have been exposed to TB, isn't sexually active at all, and doesn't have an occupation that maybe could expose him to any kind of infection either. He's not being treated for anything in particular recently, like there's no recent antibiotic or cancer history. And he hasn't been camping. He's not had a tick bite or mosquito bite. And he doesn't use drugs or alcohol at all. So he really had not much to contribute in the risk factor data gathering.
Actually, let's just review there what risk factors we should be asking for in patients with a fever where we don't know where it's coming from. So there's sexual history.
For sure.
There's travel history. There's immigration history, like have they been living in another country? There's sick contacts. There's camping, because we're thinking
outdoors
exposure.
Might not just be camping. It might have been they went for a walk in the park.
Sure. And are they immunocompromised for any other reason? Are they on chemotherapy? Right. Do they have some kind of immunocompromising state?
Right.
So
right.
That's a nice way of, just from the top, sometimes when I'm seeing a patient where I just see that their chief complaint is fever of 10 days.
Yep.
Before I even get to the HPI, I'll just start with that whole long list so that I can orient myself to where I might be, what road I might be going down with the HPI. All right. Was there anything else about the HPI, or should we move on to the physical exam?
No, there wasn't. So moving on to exam, he looked a little unwell. He was shivering, but completely oriented. He had a low-grade temperature of 38.1. Heart rate was 117. Blood pressure 152 on 92. And a normal oxygen saturation. His throat was not red, no pus. There were no cervical lymph nodes. Neck was supple. Chest was clear. Normal heart sounds, not a murmur. Abdomen soft, a little bit of tenderness in the right upper quadrant. No rashes. His joints were all fine. They weren't hot or warm or swollen. So really, the only thing on exam is, yes, he has a fever. He's a bit tacky, and he's a little bit of right upper quadrant pain and tenderness.
Okay. So now I'm thinking, either this is a biliary infection or it's something I have no idea what it is.
Right. So what do we do?
Imaging. Okay. What did you find on imaging?
Right. So it was after hours for ultrasound. So we ended up getting a CT scan. And this really showed nothing. His gallbladder looked fine. The rest of his internal organs looked fine as well.
How about a chest X-ray?
And the chest X-ray was also normal.
Okay. All right.
And the labs, I did a septic workup, very thorough. It was all normal, including LFTs, lipase, VBG, lactate, CBC, all normal.
All right. So crossing a lot of things off my list now.
Yeah, for sure.
Less likely to be a serious bacterial infection.
Agreed.
Less likely to be biliary. I'm assuming the urine was negative as well.
That's right.
Yeah, urine was negative. So now we got to start broadening our differential
That's
a
right.
bit.
Yeah.
Okay, let's go through the differential. We're not going to go through the entire differential of fever without a source or fever of unknown origin, which we'll define a little bit later. What we're really interested in is the patient who presents with a fever without an obvious source, where the diagnosis is treatable immediately, could be life or limb or vision threatening, and are easy to miss. That can be sort of occult in the history and physical and even the imaging.
Right.
So let's go through that differential.
Sure.
Let's start with infectious. So what are the infectious diseases? We know that, the top 4 sources of infection are from urine, lung, belly, and skin and soft tissue.
Right.
So what are the ones that we need to think about that are easy to miss? That's the top of your list that can be potentially life-threatening or limb-threatening or vision-threatening.
Well, I think at the top of that list has to be endocarditis. We have to think about meningitis. We have to think about epidural abscesses. In fact, I would say abscesses in places we don't expect them. So subphrenic abscesses or lung abscesses or even brain abscesses. So abscesses in an unusual location.
Okay, so in terms of infection, endocarditis is very easy to miss. You're not necessarily going to hear the murmur. Those patients, if you have some clues from the blood work, those patients are going to need an echo and triple cultures. Meningitis, sometimes it's quite obvious, but sometimes they don't have meningismus, and sometimes they aren't totally altered. Sometimes they aren't vomiting. Sometimes their headache isn't that bad. So that can be sometimes tricky. And spinal epidural abscess is a big one. Almost everyone who has a fever is going to have aches all over, including the back. And if their back pain is a little bit out of proportion to all the rest of it, you really got to be thinking about spinal epidural abscess, which can be a very tough diagnosis. All right. So that's infectious. Let's go on to inflammatory. What are the ones that are treatable, life, limb, or vision threatening that we really should pick up in the emerge that are often difficult to pick up?
Right. Well, I think giant cell arteritis is an example of an inflammatory disorder that can present with a fever that we really need to pick up in the ER.
Yeah, and sometimes those can be really subtle. Like, they just, have just kind of aches all over, and they maybe have a bit more of a headache. But, we typically learn that, it's part of our headache differential.
Right.
But I've seen patients with giant cell arteritis whose headache isn't really that bad.
Right.
And really, they just present with fever and aches all over.
Right.
Yeah. Okay. So giant cell arteritis is a big one. Anything else on the list of, serious life-threatening that we don't want to miss that are
serious
easy to miss?
life-threatening? No. Lots of things that actually should be diagnosed at some point, but not life-threatening.
Okay. Great. Then we're on to malignancy.
Right.
So, of course, there's a billion different malignancies that can cause a fever. What are the one or two that we really have to make sure we don't miss that are easy
We've
to
got to
miss?
think about the blood cancers. So leukemias, I think, have to be high on the list, and thinking about blast crises, of course. Now, you'll know that when you see the CBC.
Okay. So really scrutinizing the differential. It's not, if you just see, oh, they have a high Y count, you really need to scrutinize that differential on the CBC.
It'll be really high.
Yeah, great. Okay, so that's the malignancy. Then there's like toxicologic. What in the toxicologic or sort of other category?
Right. In the other category, there are different systems that can be involved. So think of endocrine, think of adrenal crisis, which can present with a fever, hyperthyroidism. Think about toxicological presentations. And this could be aspirin. It could be a medication like aspirin that's been taken in overdose, either intentionally or unintentionally, to cause a fever and, of course, a toxidrome that we need to be treating. It could be simple drug use. It could be a stimulant like cocaine or crystal meth that's causing an intoxication, or withdrawal syndromes, delirium tremens, and alcohol withdrawal. Obviously, of course, also life-threatening and can cause a fever. But there's also things that are, again, easy to miss, things like serotonin syndrome and neuroleptic malignant syndrome for patients on SSRIs and antipsychotics, respectively, that we need to think about.
Absolutely. Okay, so in our sort of other category and tox category, there's really serotonin syndrome, neuroleptic malignant syndrome, alcohol withdrawal, and stimulant intoxication.
Right.
From the endocrine, there's thyroid storm, which sometimes isn't that obvious, and adrenal insufficiency, which also can be pretty tricky. Okay, so that's a great list we've got there.
Right.
Okay, so we've hammered through the differential diagnosis of treatable, life, limb, or vision-threatening but easy to miss diagnoses that present with fever where we can't figure out what's going on. What happened to this patient?
Well, he got admitted to the hospital for fever not yet diagnosed. He was seen by our infectious disease team as well as our rheumatology team, and he had a battery of tests done, most of which were negative, including HIV and Legionella, parvovirus. He had another CT scan, head to toe. It was also negative. He had more blood cultures, also negative. The one test that came back positive was, drumroll please, his West Nile virus serology.
So let's talk about West Nile virus. So this guy hadn't been camping. He wasn't covered in mosquito bites.
Maybe gone out for a walk in the streets of Toronto.
Okay. So tell us a bit about West Nile virus. What do we need to know about it?
Right. So it's a virus that has been circulating, at least in Ontario and across Canada. It's become endemic in Canada for the last 20 years. It mostly causes asymptomatic disease. And among those who actually get symptoms, it typically is fever and malaise, similar to what my patient had, or a more concerning encephalitis type picture, which can have different variants, including flaccid paralysis or Parkinsonian features. And of course, those patients end up being quite ill. This is, of course, transmitted by mosquito. Birds are a reservoir. So really, prevention from mosquito bites is really the only way of avoiding this illness. And treatment is just supportive at this point.
Okay, so generally not life, limb, or vision threatening unless they have encephalitis, flaccid paralysis, etc.
Yes.
And they're usually going to present either with nothing or a bit of a fever.
Right.
Like this gentleman did.
Right.
But that's good to know about West Nile virus. Excellent. Any other learning points from this case you'd like to tell us about?
Yeah. So this patient ended up having fever for 20 days, which actually means that he didn't quite fulfill the criteria for an entity called fever of unknown origin. The definition of fever of unknown origin requires that you have a temperature of 38.3 or something like that. There's a bit of debate about whether it should be something lower than that or not. But anyway, plus 3 weeks of it. So he was just shy of 3 weeks. But what's interesting is to read that about half of the people who have fever of unknown origin don't end up getting a diagnosis. And that portion who never gets a diagnosis ends up doing quite well. Now, that's assuming they have a big workup and nothing shows up. So the workup is important for that group, but a good chunk of them are never going to get diagnosed with anything, and that's probably okay.
Okay, so that's good to know. So I don't have to feel so bad if I don't know what the cause of a fever
you
is
don't.
when I discharge a patient
That
who's
said,
doing well.
I would say those folks who are stable enough to go home really do need follow-up because they do need that workup if they really are having fever for that length of time.
Absolutely. All right. Well, that's good to know that half of them, they never find out, and that most patients do very well, actually.
Yeah.
Okay, great. Well, thanks so much, Dr. Lazier, for teaching us a little bit about West Nile virus and for your great case.
Oh, you're very welcome.
And some great learning points about the differential specifically of treatable, life, limb, or vision-threatening diagnoses that are easy to miss when people present with a fever.
Okay. Thank you.
Last time on EM Quick Hit 70, we took a physiology-first approach to traumatic pneumothorax with Andrew Petrosoniak, and he emphasized stratifying patients into 3 buckets: peri-arrest, unstable, and stable, because physiology determines urgency, imaging, and tube choice. In unstable patients, hypoxia or hypotension with chest trauma is enough to act. Classic signs are late. Ultrasound beats auscultation. Absent lung sliding plus instability. Decompress first with finger thoracostomy followed by a large bore surgical tube. For stable patients, we covered the imaging thresholds, more than 38 millimeters on chest x-ray, more than 35 millimeters on CT, and the need to integrate numbers with respiratory status and the presence of hemothorax. Pigtails are reasonable in stable patients, but large bore tubes still matter in unstable or complex cases. In this part 2, Andrew's going to take us deeper into his real-time bedside decision-making, how to synthesize physiology, imaging, and trajectory when it counts most. Take it away, Andrew.
Okay, we're back for part 2 of the chest tube quick hit that clearly didn't end up being so quick. So as a reminder, our case that we're using to guide the discussion is a 43-year-old male involved in a high-speed MVC who had transient hypotension that's now improved spontaneously to 105 on 60, but he's still requiring O2. Initially, oxygen saturations with EMS were 85, and that improved to 99% on a non-rebreather, and he's been titrated down to about 6 liters on nasal prongs. But the rest rate is still a bit fast, between 28 and 30. His GCS is 15, he has an obvious seatbelt sign across his chest. There's no palpable subcutaneous emphysema, but he remains tachycardic, and he has no underlying medical conditions. All right, the first question I think that comes up in the management of these patients is, who needs a needle decompression? And while we're going to talk about chest tubes in a minute, I'd like to agree that we all stop using needle decompression. And while never and stop completely might seem a bit strong, and I try not to use those terms, I just can't imagine a circumstance in the ED where needle decompression is a good idea. The time it takes to gain absolute certainty in decompressing the chest is well worth it versus wasting time looking for the right catheter, then inserting it, hoping it drained, meanwhile avoiding the thing that the patient actually needs, which is a chest tube. And there's ample data to back me up here, suggesting that the probability of entering the thoracic cavity is low because the chest walls are thicker than many needles. And even if you go into the lateral aspect, the 4th or 5th intercostal space, which is better, it's just too unpredictable. And these patients are too sick to rely on a needle. So let's agree to forget about needle decompression in the ED. Maybe there's a role for it in a resource-constrained environment like a pre-hospital setting, but in an ED, I think it's not a thing. All right, so let's talk about what kind of chest tubes we're going to use. This focus really kind of is between a small bore chest tube, which most of the time people think about is around a 14, 16, 18 French pigtail, or a large bore chest tube, which in the literature is greater than a 20 French traditional chest tube, or at least equal to or greater than 20 French. And so referencing the 3 categories I mentioned at the beginning of the podcast, the peri-arrest, the unstable or stable, and based on patients excluded for most of the trials, comparing large and small bore chest tubes, it's my practice in unstable or peri-arrest patients to only use traditional surgical large bore chest tubes. And for me, this is typically a 24 or a 28 French. These need to go in quickly. And sometimes I just need to do a finger thoracostomy, which is my preferred approach and what I advocate for when asked in these patients. And then I follow that up with a chest tube. The other caveats that I include in my decision-making is if there's substantial chest trauma causing disruption of the chest wall, like a flail segment or subcutaneous emphysema. And while the studies didn't necessarily exclude these patients, I really don't like putting pigtails in when I feel a lot of sub-Q air, since it just increases the risk of falsely thinking you're in the thoracic cavity at the beginning of the procedure when you're aspirating or looking for air. But for the stable patients who need a chest tube for a traumatic pneumothorax, a large meta-analysis in 2023 found that small bore or pigtail chest tubes are at least equivalent to large bore ones. And in fact, across a range of outcomes that included incidence of VATS, initial output, tube duration, and pain, they all favored smaller bore chest tubes. And probably most importantly, there was no significant difference in failure rates between the two. My experience is definitely that I'm doing more pigtails for isolated traumatic pneumothoraces in these stable patients. And it also seems to be the case in referring centers, smaller centers. They're also sending more patients with pigtails. And overall, this seems to be like an evidence-based and right move, both for the clinicians, the patients, and the outcomes. I'll provide a few points of caution for pigtails and sometimes when I deviate from where the evidence would otherwise support it. So number one, if the trauma happened a few days ago, there's just a greater risk of there being some complications, adhesions, potential concomitant pneumothorax, some degree of a complication, clotted blood. So I'd go ahead and get a CT first before I go in and put in a pigtail. Also, if there's no significant pneumo on chest x-ray, I at least wait until the CT. And really what I'm looking for is a good amount of space between the lung and the chest wall. And if there's not that, then personally I go with just a traditional surgical chest tube because I don't like to rely on the wire and needle when the lung is nearly abutting up against the chest wall. Number three, as I mentioned previously, if there's lots of subcutaneous emphysema, I avoid pigtails. I think it's too easy to be tricked that you're aspirating intrathoracic air when in fact you're in subcutaneous tissue. Number four, a concomitant large hemothorax. And we'll talk about this in a bit, but I just am not a big fan of using pigtails in these patients. And number five, in trauma, I almost always get a CT before putting in a pigtail. I just like to know that I'm not dealing with a bunch of unexpected adhesions or some other concomitant trauma that I think the patient would manage better with a more traditional large bore chest tube. And I realize lots of people go ahead with just the x-ray, but I'm just providing you a sense of my practice. It's very different than the patient with a spontaneous pneumo. And I think all trauma patients with a large enough pneumo requiring a chest tube, if there's time, should get a CT, especially looking for other injuries, and as it might change your decision-making. So if feasible, get the CT before doing the pigtail, but I realize certainly you can go ahead with it if everything seems fairly straightforward. Now, in the case of the obvious hemothorax, among stable patients, there's data that also supports the use of pigtails. A recent RCT of 119 patients found that small caliber 14 French pigtails are equally as effective as 28 to 32 French chest tubes in their ability to drain traumatic hemothorax with no difference in complications. And patients also reported a better experience. I'd say though, despite this data at our center and my own personal practice, our trauma teams are more in favor of still using 24 to 28 French chest tubes for significant hemothoraces. And perhaps this is just dogma and maybe we're a bit more of a conservative group, but we haven't really shifted over our practice yet for these types of patients. But if you do, and I do think it's justifiable, just some caution as it's relatively newer data that's guiding this. So back to our patient who is requiring a bit of oxygen, had transient hypotension, but is now stable. The chest x-ray shows a moderate pneumothorax. There's no evidence of a hemothorax. And so for this patient, I'd put in a pigtail. Though I'd probably bring him to CT first, as we can get these fairly quick at our center, and logistically it just makes sense. But if you can't, it's reasonable to proceed with the pigtail, especially if there's ample distance from the lung to the chest wall. All right, what else should I know about chest tubes? I get these questions all the time. A few things, and I'm going to list out 6. So number 1, landmarks are essential. I've never seen a chest tube inserted too high, but I've seen so many that are dangerously too low. The triangle of safety is a great landmark. It's the border of the lat and the pec and the axilla superiorly, and that's a great starting point. And the apex comes together basically at the lower edge of where the axilla hair is. And I'll cross-reference that with the nipple, and I usually then go one intercostal space above that. Number 2, I'm not a fan of putting in chest tubes at the second intercostal midclavicular line. I think it's just worth getting good at one site. So for me, it's always the 4th intercostal space. Number 3, I shoot a chest x-ray before I fully secure the tube. That way, if I need to make any adjustments, I can. And before I put in the tube, I measure holding the chest tube over the patient's chest to approximate how deep I should insert the chest tube, usually somewhere around 10 to 12 centimeters. Number 4, give a dose of antibiotics at the time of insertion. 1 gram of Ancef, very reasonable. Think of it like the way that surgeons operate. They give a gram of Ancef before they make their first cut. And this is now guideline recommended as it reduces the risk of empyema. Number 5, when I insert a traditional surgical chest tube, I always spin the tube in my hands to make sure it can spin freely. So hold the tube, spin it in your hands, kind of like a toy top. And this means if it can do that, then it's not caught in a fissure. If it doesn't spin freely, then it means that it's caught in something. And that it's going to need some repositioning. And number 6, when I'm doing a traditional chest tube, a large bore chest tube, before I insert the chest tube, I put my finger in and I always feel 360 degrees to make sure that I feel pleura all the way around. And it should feel like a linoleum floor, kind of like the floor you're probably standing on in the hospital. If it doesn't feel like that, you're likely not in the right spot. Or perhaps you feel some adhesions and those need to be broken down. And that's it. Here's the recap. Number 1, patient categorization is critical for chest trauma. Decide if they're peri-arrest, if they're unstable, or stable. Number 2, patients who are peri-arrest or unstable should get a surgical or a large bore chest tube. Number 3, if the patient's stable, then a pigtail is reasonable, though consider a surgical chest tube under certain circumstances where you think there's adhesions, it's been a few days since the trauma, or there's lots of sub-Q emphysema. Number 4, when possible, even for those getting a pigtail, I like to get a CT. And number 5, for hemothoraces, the evidence suggests that pigtails are also reasonable, though in my practice, I'm still using
no matter where
surgical
you
chest
practice,
tubes, usually
there
a 24
are moments
French.
when decisions can't wait. Maybe imaging isn't available or the system is too busy and you still need clear answers right now. That's where a POCUS fellowship makes all the difference and gives you the confidence at the bedside. It helps you decide that you can manage locally and when it's time to escalate care. The Rural Ultrasound Fellowship is a 1-year, fully online POCUS training program you can complete while working full-time, taught by international faculty. Learn more at ruralultrasound.com. Built for real-world decisions. All right, next up we have a new quick hitter, Dr. Adriana Rowe, an EM toxicologist who works at St. Paul's in Vancouver. And she's going to explain to us why we need to know about medetomidine withdrawal. Now, in case you're like me and you know nothing about medetomidine, it's a veterinary sedative and it's surfaced in EDs everywhere because on the street, it's mixed in with fentanyl, and withdrawal from it, which can be life-threatening, requires specific management. All right, here's Adriana Rowe on medetomidine withdrawal.
You start your morning shift taking handover from the overnight physician. They ask you to reassess a 43-year-old man who was brought in last night after a witnessed opioid overdose. Bystanders report he became unconscious with agonal respirations minutes after smoking unregulated fentanyl. Naloxone improved his respiratory effort, but he remained sedated. On arrival, his vital signs were within normal limits. He was drowsy but withdrew to pain in all 4 extremities, and there were no signs of trauma on his physical exam. His labs, ECG, and CT head were unremarkable. He remains in the emergency department due to persistent sedation. 2 hours into your shift, a nurse asks you to reassess him. He's now awake, but something's clearly off. He's mumbling, tremulous, restless, with dilated pupils, and he's not responding appropriately to questions. He tried drinking some juice, but subsequently vomited. His vitals now show a heart rate of 155, blood pressure of 170/100, respiratory rate of 25, oxygen saturation of 95% on room air, and temperature of 37 degrees. He has persistent vomiting despite multiple antiemetics and can't tolerate oral medications. He receives multiple doses of IV hydromorphone and diazepam for presumed opioid and benzo withdrawal, with some improvement to his restlessness but minimal change to his vitals and hypoactive delirium. Your nursing colleague says to you, "This doesn't look like opioid or benzo withdrawal. What do you think is going on?" You wonder whether this could be medetomidine withdrawal. Medetomidine is a veterinary sedative that has increasingly been detected as an adulterant in the unregulated drug supply. It's a potent, non-selective alpha-2 agonist, pharmacodynamically similar to xylazine, clonidine, and dexmedetomidine. It acts on central alpha-2A receptors to cause sedation, analgesia, and suppression of central sympathetic output. Peripherally, activation of alpha-2B and 2C receptors causes vasoconstriction. Contamination of unregulated opioids with benzodiazepines and alpha-2 agonists has led to increasingly frequent presentations of profound and prolonged sedation following unintentional overdoses. Naloxone corrects respiratory depression related to opioid toxicity, but it doesn't reverse sedation from benzos or alpha-2 agonists. Alpha-2 agonist toxicity causes sinus bradycardia, often without significant hypotension. Acute toxicity is usually manageable with observation and standard supportive care. The bigger challenge here is withdrawal management. As early as 6 hours after last use, patients can develop alpha-2 agonist withdrawal. Classic features include severe tachycardia, hypertension, mydriasis, hypoactive delirium, and severe nausea vomiting that's often refractory to antiemetics. Severe and prolonged autonomic dysfunction has led to posterior reversible encephalopathy syndrome, or PRES, myocardial injury, hypokalemia, and lactic acidosis in these patients. Medetomidine withdrawal presents several challenges to emergency clinicians. First, it's a clinical diagnosis. There's no rapid, widely available confirmatory test for medetomidine exposure yet. Second, the unregulated drug supply is heavily contaminated. Patients may be withdrawing simultaneously from opioids, GABA agonists, and alpha-2 agonists, and these syndromes have overlapping clinical features. You should think about medetomidine withdrawal in patients who are using unregulated drugs when symptoms begin within 24 hours of stopping drug use, when hypertension and tachycardia are severe or refractory despite appropriate treatment for other withdrawal syndromes, when vomiting is prominent and not responding to antiemetics, and when hypoactive delirium is present. Unlike GABA withdrawal syndromes, seizures, agitation, and hyperactive delirium are less typical with medetomidine withdrawal. Lastly, treatment can be logistically challenging. Involve your addiction medicine colleagues early to assist with management. Your goal in the emergency department is to restore alpha-2 agonism in these patients. Regardless of which agent you choose, dosing can be challenging. Patients may have high tolerance and require substantial doses and ICU-level care to control withdrawal. These patients are much more likely to become bradycardic and hypotensive with aggressive alpha-2 agonist replacement, so always consider the full clinical picture when selecting your dosing strategy. In patients who can tolerate oral medications, clonidine is your simplest option. If tachycardia and hypertension are mild, or if there are concerns about other underlying medical issues, start with 0.1 to 0.2 milligrams orally. In patients with severe hypertension and tachycardia, a higher starting dose of 0.3 to 0.5 milligrams is appropriate. Peak onset of effect is expected within 2 hours of oral administration, so dosing can be repeated every 2 to 4 hours. For treatment of vomiting, start with antidopaminergic agents like metoclopramide or prochlorperazine. Ondansetron and dimenhydrinate are unlikely to work here. If the patient cannot tolerate oral intake, or if symptoms are refractory to clonidine, critical care consultation for a dexmedetomidine infusion is your other main option. Depending on hospital policies, starting a dexmedetomidine infusion in the emergency department may or may not be feasible for you. If you can run a dexmedetomidine infusion in your department, it can be started at 0.2 to 0.5 micrograms per kilogram per hour and titrated every 30 minutes. Giving a loading dose of 1 microgram per kilogram over 10 minutes is reasonable for patients with severe hypertension and tachycardia. Treatment with a high-dose dexmedetomidine infusion for multiple days is sometimes needed in these cases. Modern emergency medicine requires creativity and troubleshooting in resource-constrained settings. If an IV dexmedetomidine infusion is not an option in your department while awaiting transfer to ICU, intranasal or intramuscular dexmedetomidine may serve as a bridge. Confirm with your local pharmacist, but typically, the intravenous 100 microgram per ml solutions that are stocked by hospital pharmacies can be given intranasally or intramuscularly. In an era of an increasingly contaminated, unregulated drug supply, we need to expand our differential when withdrawal doesn't behave the way that we expect. Severe or refractory hypertension and tachycardia with hypoactive delirium and intractable vomiting should prompt consideration of medetomidine withdrawal. And when you suspect it, your treatment should focus on the underlying mechanism, restoring alpha-2 agonism.
Fantastic. So opioid withdrawal that isn't behaving as expected should raise concern for the possibility of medetomidine withdrawal, and clonidine is our go-to antidote. Thank you so much, Adriana. Next up is Justin, and he's going to give us his take on the pediatric PCARN C-spine decision tool.
So this might end up being a little bit longer than my standard EBM segment, but I think it's important because honestly, I'm worried. I think this could end up hurting a lot of children. And to some extent, I'm a little bit worried that the horse is already out of the stable. And so what I'm talking about is the PCARN C-spine rule. So let's get into it. Now, like everything that comes out of the PCARN group, this is a huge, high-quality study that we all need to know about. We need to know the research. But I think it's important to separate high-quality research from the resulting rule. Just because your rule shouldn't be used doesn't mean that the research wasn't valuable. So let's talk about the research. This is a big multi-center effort from level 1 trauma centers, and that's important. We'll come back to that. And it's a 2-part study, derivation and validation. They included children with blunt trauma who either arrived by EMS to the trauma center, were a trauma team activation, or who had C-spine imaging done. So this is a high-risk cohort. The derivation cohort had almost 12,000 kids. The validation cohort had 10,000 kids. So this is huge numbers. But one concern with this study is that they did miss a huge number, more than 30% of the eligible kids, and they don't explain why. And they come up with a 2-part rule. There are 4 high-risk features, and they are very high risk. And so those would be a GCS between 3 and 8, unresponsive on the AVPU scale, the need for intervention in any of the ABCs, airway, breathing, circulation, or a focal neurologic deficit that is present in the emergency department. If you have any of those, you have at least a 10% risk of a C-spine injury, and they suggest you get a CT scan. There were 156 children who had C-spine injuries who did not have any of those high-risk features, though, and that ends up representing a risk of 1.4%. And I think that's going to be the crux of this paper. If you don't find any of those high-risk features, you already have a very low risk of injury. And this is in the children who had trauma team activations. So it's going to be an incredibly low risk of injury in your hands, in the community emergency department, and the children not transported by EMS. And so the question is, can this rule actually make that tiny risk any better? To try to catch that last 1.4%, they add 5 more features. Self-reported neck pain. So the kid actually has to volunteer that they have pain. You can't ask them about it. Any altered mental status. Substantial head or torso trauma. And substantial here means needing surgical intervention or an admission to hospital. Or neck tenderness on exam. And if you have any of those, the final rule suggests an X-ray in that group. How did the rule perform? Well, actually not all that great. The sensitivity is about 94%, but the 95% confidence intervals go all the way down to 90%. So this rule will miss between 5 and 10% of C-spine injuries, which is not ideal. And like all rules, the specificity is not great, about 60%. So before I even get into the major limitations of this paper, I think you want to ask, is 95% sensitivity good enough for you to adopt a rule when we're talking about C-spine injuries? Doesn't sound great to me. Now, the authors will emphasize the 99.9% negative predictive value, but there are all sorts of problems with using negative predictive values, and at least to be fair, you have to also mention the positive predictive value, which is only 3%. So again, let me say, this is tremendous research. We can learn a lot about pediatric C-spine injuries in very high-risk pediatric trauma, but reading this paper has me very worried. This rule is not ready to be used for a large number of reasons, but if people start using it, I think it will almost certainly lead to a dramatic increase in imaging use, and that will ultimately hurt a lot of kids. So to start, you have the usual limitations of any decision rule, right? This hasn't been externally validated, and decision rules frequently look worse when they're tested in external populations. It hasn't been tested against the gold standard of physician judgment. We don't have an implementation study, so we have no idea if this would decrease or actually increase imaging in real-life practice. And there are lots of reasons to think that this rule would end up increasing imaging a lot and causing a lot of harm. First of all, this cohort represents an incredibly high-risk population presenting to level 1 pediatric trauma centers. And even in this very high-risk population, the baseline risk for C-spine injury is only about 1%. So for the average child presenting with less severe trauma to the average emergency department, the baseline risk is going to be much lower, and the false positives will absolutely swamp the true positives using this rule. Now, the authors claim that this rule would decrease imaging in their centers, but that's in a baseline population where 60% of the kids are being imaged. 17% of the kids are receiving a CT scan. I hope that highlights how different this population is from what we see, where C-spine imaging rates are way below 1%. Now, one minor caveat about this paper, they recommend CT scan for the high-risk group and X-ray for the middle-risk group and no imaging for the lowest group. Now, I think it's important to recognize that those recommendations are not science-based at all, right? They didn't test that recommendation. They don't even talk about likelihood ratios or a target post-test probability. So aside from expert opinion, I guess, they provide no real justification for using those tests. Now, that makes sense to me, but they are not science-based. It's quite possible that X-ray is actually adequate in the high-risk group, or that CT is actually needed in the low-risk group. I think people will cite this paper for those imaging choices, but this paper has absolutely no data on the best imaging test at all, despite it being included in their final rule. But I think that's the minor issue. The big problem with this study is probably that they forgot to include or chose not to include a control group. Without comparing this rule to the current gold standard, which is just physician judgment, you have no idea whether this will make your practice better or worse. But I want you to think about your practice for a second. How often do you struggle with this decision? How often do you order neck images in children? How many missed C-spine injuries are you seeing in the pediatric cohort? For the most part, this is a non-issue. So adding a decision rule that makes it seem like an issue is almost certainly going to make us worse at our job. And considering that this is a non-issue around the world and that pediatric C-spine imaging is ordered very rarely in the average emergency department, I think the only possibility is that this is going to make us order more tests. Now, without implementation studies, we can't know for sure what's going to happen in the real world. But I want to run you through a thought experiment that I think will make it very clear that if you start using this rule, if this rule starts being used widely, it will cause a dramatic increase in imaging. So let's imagine a world in which this rule is used perfectly. In this scenario, the rule is only applied after the imaging has already been ordered. The patient is sitting there in radiology waiting to get their test. In that setting, the rule can't possibly increase imaging because the test is already ordered, and so it can only possibly decrease testing. But if you take a step back, what does this rule say? It says that you can cancel that imaging order if the patient is not altered, required no intervention for their ABCs, has no focal neurologic deficits, has no neck pain, has no substantial head or torso injury, and has no tenderness on exam. Okay, think about that patient. In your current practice, would you ever order imaging on that patient? Why in the world would you order imaging on a patient with no pain, no tenderness, no neurologic findings, and no other substantial injuries? That makes absolutely no sense at all. No clinician I have ever worked with would order imaging on that patient. We sometimes get lost in the scientific jargon of a paper and we lose track of common sense. Forget about all the numbers in this paper and just think about what the rule is saying. No emergency physician would ever order a C-spine image on a patient who is awake with no pain, no tenderness, no neurologic deficits, and no other substantial injuries. Or if you were ordering imaging, you probably had some other really good reason, and it's not clear that a rule with a sensitivity of 95% should talk you out of the test. If you were never going to order imaging on that patient in the first place, there is no possible way that this rule could decrease imaging in your practice. I will say that again. There is no way this rule could possibly reduce imaging because no sane emergency physician would ever order imaging in the low-risk patient being described. You don't need this rule because you are already excluding these patients using your basic clinical judgment. However, we know the rule will not be applied in this perfect scenario. It won't be applied only after imaging has been ordered. It will be applied in everyone. It will be applied in patients you currently would never even consider imaging. You'll get worried about the exact definition of substantial head injury, or you'll waffle about the fact that the kid might have said their neck hurt 3 hours ago on scene. Or you'll wonder whether the kid's natural aversion to being touched is maybe actually tenderness. You'll worry that other people might judge you about a miss because there was an objective rule they can point to that's saying you should have imaged. Instead of using this rule as a one-way rule-out test, just like all of our other rules, you'll use this rule to rule in. You will let it convince you to order imaging. And so you will image children that you never in the past would have imaged. Now, in some clinical scenarios, increased imaging might be acceptable if it results in fewer missed injuries. Pediatric C-spine is just not one of those scenarios. One thing I can tell you for certain, there is not an epidemic of missed cervical spine injuries. We don't need help making this diagnosis. We aren't missing these children, so any increase in imaging will represent pure harm. We need to see implementation studies to be sure, but I think this thought experiment makes it very clear that this decision rule will dramatically increase the use of C-spine imaging in children, and that will result in tremendous harm. So let's get to the bottom line. This is a high-quality research study. This results in the derivation and validation of a pediatric C-spine rule in a population of extremely high-risk pediatric trauma patients. This rule should not be used clinically. Now, if you happen to work at a pediatric trauma center and you're seeing a high-risk trauma patient as part of a trauma activation, and you're considering ordering a PAN scan and you want to use this rule to talk yourself out of ordering the C-spine portion of the imaging, look, I'm not going to argue with you, even though I will say the rule is not proven in that situation at this point. However, if you are working in any other setting, this rule will almost certainly increase your use of imaging. It was not studied in your population. It has not been subjected to the necessary external validations. It has never been compared to the current gold standard of clinical judgment, and we have no implementation studies. This is just not a condition that we are having a hard time with. In fact, this is a pretty easy condition to assess. Forget about the rule. Examine the patient exactly like you are currently doing. Your clinical judgment is almost certainly better than any rule that will ever be created.
Insightful and thought-provoking as usual. Thank you so much, Justin. We welcome any comments in the show notes with your thoughts on the PCARN C-spine rule. Next up, before we get to our brand new coaching series with Katie Lynn and Sarah Gray, we have a fellow podcaster and the first ever paramedic on EM Cases. It's been way overdue, so I apologize to all the amazing paramedic listeners out there. Here's Zach Cantor.
Hello, everyone. I am Zach Cantor, paramedic and host of the Critical Levels podcast. Today, I want to talk about something that happens on every single paramedic call. Something so routine, so ordinary, that we barely think twice about it. But when it goes wrong, it can change everything. And I am talking about handover. Now, before you roll your eyes, let me tell you why this is something that really matters. We all know handover is important, but here's the thing. The evidence says it's critical. A couple Canadian studies have looked at this. Studies have shown that up to 30% of the information shared by the paramedics is not recorded by the receiving trauma team. They found that key information, like a complete ABCDs, was missing in almost 90% of the cases. Almost 80% of patients were transferred to the bed before handover, and over 60% of handovers had parallel conversations happening while the paramedics were speaking. The result? Lost information, repeated questions, interruptions, which happened almost 90% of the time, and misaligned expectations between the teams. The bigger problem, though, reductions in the quality of patient care. And other studies have confirmed what most of us already feel, that handovers without structure lead to confusion and distraction. When teams used a consistent format like I missed, interruptions dropped, confidence went up, and everyone agreed that communication was clearer. They also found that the best handovers were short, structured, and began before moving the patient, with everyone quiet, eyes on, and focused. And so the message here is clear. Better handover equals better outcomes. This is not about courtesy. It is about patient safety. So how do we make that happen? Reliably, quickly, and with less chaos. The first step, own the room. Before you start talking, make sure the right people are listening. Ask who's in charge. Wait until they're ready. The more times we tell the story, the more information gets lost. This is classic broken telephone. And remember, there's no such thing as multitasking. If you're given a report while they're moving the patient, you're not being heard. I love the mantra, hands off, eyes on. 1 minute of focused listening can save 10 minutes of confusion. Next, we do what the research tells us works. We use structure every time. A structured handover tool gives everyone a shared mental model, a roadmap that keeps the team on the same page, fast, and keeps the message consistent. The one that's been tested and validated across systems is IMIST AMBO. It's clear, it's fast, it works. Let's break it down. I, identification, the name, the age, and who you are. 0% of the paramedics introduce themselves, and only 43% mentioned the patient's name. M, mechanism or medical complaint. Why we're here. What happened. I, for injuries or information. The key findings or the relevant history. S, for signs and symptoms. The ABCDs, the vitals, the GCS, the numbers that tell the story. T, treatments and trends. What you did and how they responded. That's IMIST. Then we go on to AMBO. A, allergies. M, medications. B, background. So this is your past medical or your social history. And then O, for other. Anything else that's clinically relevant here. That's it. 30 seconds for IMIST, 30 for AMBO. Fast, focused, functional. Here's the key. This structure creates predictability. The predictability creates clarity, and clarity in the middle of chaos saves time and sometimes lives. Research shows us that when both teams use the same format, interruptions drop, confidence rises, and understanding improves. It's not about memorizing an acronym. It's about speaking a language that everyone understands. So if we know this works, why don't we always do it? Well, maybe because it feels routine, or maybe because the room's chaotic, or maybe because nobody ever taught us to treat it like the intervention that it really is. Because that's what handover is. It's an intervention. It's the bridge between chaos and continuity. It's what turns what happened out there into what happens next. We've all seen it, that nurse chasing you down the hallway to clarify a detail. That's not failure. That is a gap, and it's a gap we can close. Handover isn't glamorous. You're not going to talk about it at the bar. It won't make an Instagram reel. But it's one of the most consistent, high-stakes interventions that we perform. Every patient deserves clarity. Every provider deserves context. So, the next time you roll through those emergency department doors, take a breath, get their attention, tell the story, then move the patient. Hands off, eyes on, because this isn't a voicemail, it's a handover.
Love it. Thanks so much, Zach. Now, if you're keen on more paramedic topics that EM docs need to know about, that EM docs can learn from, please let me know what else you want to hear from Zach. Let's take a little break to hear from one of our sponsors, Metricade, the experts in complex physician scheduling since 2012. Metricade's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricate's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricade.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES. I am now so pleased to introduce to you another brand new EM Quick Hit series and the debut of Katie Lynn hosting. This series is called Coaching the EM Mind. I won't give anything away, and I'll just let Katie take the reins from here.
Picture your last string of shifts. Were you tired? How well did you sleep before and after? Were you relying on that caffeine fix to keep you going? And did you take any breaks on shift to eat, use the bathroom, or catch your breath? Or like me, did you power through your exhaustion, call yourself an expert at intermittent fasting, ignore your own evolving pre-renal AKI, cram in some extra meetings between shifts at the cost of a compounding sleep deficit, and lean on the I can do hard things mindset until it was all over and you could finally crash? Hello, EM Cases listeners. It is my pleasure to introduce a new Quick Hit series to the podcast today. Welcome to part 1 of our series on Coaching the EM Mind, Critical Skills for Career Longevity and Joy, with guest expert, Dr. Sarah Gray. We all know that emergency medicine is inherently stressful and high stakes. It's part of why we love it. I think if you're listening to this podcast right now, odds are you already know what burnout feels like. I know I do, and I know I'm not alone. I also know that despite how hard it is out there, there's a reason we chose to do this work, why we continue to choose it every time we show up to our shifts. Whether it's the expertise we offer to patients in their most vulnerable moments, the medical puzzles we get to help solve, or the community of practice we build with the colleagues around us. For all the moments that remind us why this work matters, I also want to take a moment to acknowledge that we matter as well. And yet often we're so bad at looking after ourselves, and that makes it hard to keep doing this work for the long haul. But just like any other skill, with practice, we can do better. So instead of focusing on the problem of burnout, which we're already so familiar with, this series will explore practical solutions. Solutions that are based on both evidence and boots on the ground experience. Solutions that can help us all perform better and preserve the joy that led us to EM in the first place. This is part 1 of our Coaching the EM Mind Quick Hit series, where we'll begin by exploring practical strategies to address our physiologic needs, both on and off shift. It is my great pleasure to welcome Dr. Sarah Gray to the podcast. She's a familiar voice on EM Cases and beyond, an associate professor with the University of Toronto, an emergency physician and critical care physician at St. Michael's Hospital in Toronto, Canada, a well-recognized public speaker and educator, and a certified personal and professional development coach. I can't think of a better voice to walk us through this topic. Sarah, welcome to the podcast.
Hi, Katie. Thanks so much for having me. I'm happy to be here with you.
Wonderful to have you. Sarah, you bring together the best of both worlds when it comes to clinical practice and coaching expertise. In EM, we often pride ourselves on our ability to power through hardship and perform well under pressure. Yet we would never expect a professional athlete to go into a game or competition sleep-deprived, hungry, and dehydrated. In fact, in medicine, we often wear our exhaustion as a badge of honor. I, myself, am definitely guilty of this. Sarah, why do you think it's become so easy and acceptable to neglect our own basic needs on shift? And what was your wake-up call to start paying attention to your own body?
Okay, so Katie, I think you are absolutely right. As healthcare providers, we routinely neglect our own basic needs. And my opinion actually is that I think we're trained to do this during medical school and residency, where we work crazy hours with no breaks, no regular meals, no sleep. And this culture is quite glorified in medicine to be that person who doesn't need to eat or sleep or use the bathroom. And we learn to focus all of our energy on our patients while ignoring all of our own needs. And so, at least for me, I definitely deeply embraced this culture during my training. And then I did have a big wake-up call that many of us do. So for me, it came when I had been on staff for a couple years and I was having a rough time. I had a baby at home and a toddler, so I was not getting any sleep. My pregnancies had been rough and I hadn't been to the gym probably in about 3 years. So my physical health was terrible. And then tragically, we had 2 close friends commit suicide within a few months of each other. And this was really a terrible time for me emotionally and psychologically. I still miss them so much. And it really made me take a hard look at how I was living and at what was important to me. And I started thinking hard about my own well-being, because if these 2 amazing friends, I mean, they were smart, successful, incredible people, if they could be struggling so much that they could come to suicide, then I thought, I need to make sure that doesn't happen to me or to the people in my family. And so I started actively trying to turn my life around. And I was really overwhelmed at the time, overcommitted to at the time. So I had to start really small, just to start the ball rolling in the right direction. And so that's what I did. I hired a trainer and I started going to the gym once a week. That was my first tiny move towards getting healthy again.
Thanks for sharing that, Sarah. I think that your experiences resonate with a lot of those of us who've worked in medicine or been in medicine. And I think if you've walked this path for long enough, we lose people along the way. And that is a wake-up call for so many of us. I'm really glad that we're talking about it as well, because I think that helps us to start addressing the problem and start thinking about what that means in our own lives and what it looks like to try and walk a different path or to sort of change course. I'm really curious as well. We've talked about these big moments where we lose people in our lives. We have these big wake-up calls. But I'm curious, in your experience, what are some of the early warning signs that we might be able to look for further up the path, kind of upstream, that indicate we have unmet physiologic needs that might be impacting our mindsets, our performance, our mental overall wellness?
Yeah, so great question. When you're thinking about what those early warning signs are, I tend to check in around 4 categories: around sleep, around fitness, around nutrition, and around stress. So when you're thinking about your sleep, are you falling asleep on your commute? Have you fallen asleep standing up in an elevator recently? Did you fall asleep even at home during family movie night when you were supposed to be awake? Check in on your health and fitness levels. Are you going to the gym? How was your last checkup with your family doctor? In terms of your nutrition, have a think about how you're eating, about your cholesterol level. And last, when it comes to your stress level, how are you feeling? Are you overwhelmed? Are you ditching showing up for your friends or for your hobbies or for activities you love because you feel you don't have time? Are you walking into shift feeling calm and confident, or are you walking in with a sense of stress or even dread? And so checking in on our basic physiology is a really great starting point.
I love that. So thinking about our sleep, our fitness, our nutrition, and our stress levels as those early warning signs that we might have some unmet physiologic needs. We'll talk a little bit later on in this episode about how some of those early warning signs can elude us in the early stages, and it might be the people around us who actually notice those clues first. And so for our listeners in the audience, this is a really good moment to take a pause and reflect on what your personal alarm bells look like, because they might vary individually. But now that we know a little bit more about what to look for, I want to switch gears a bit and talk about some strategies. Let's start with sleep, that first one that you mentioned. We recently did a deep dive on sleep strategies for shift workers with guest expert Dr. Mike Mack. Listeners can tune into EM Cases podcast episode 207 to listen to the full episode. But I think it's worth reiterating and elaborating on some key points because they are so important for our performance and well-being, both on and off shift. So Sarah, we know that EM work is generally synonymous with shift work. And we know that shift work messes with our health. But can you remind us how shift work messes up our sleep and how it impacts both our health and clinical performance?
Absolutely. Okay. So on the health side, shift work is associated with metabolic syndrome, which includes diabetes, hypertension, dyslipidemia, abdominal obesity. It's also associated with cancer and is now considered a carcinogen. It also has significant psychological impacts and is associated with depression and anxiety. So there are huge health impacts from shift work. And then in terms of our clinical performance on shift, we know that night shift work specifically is associated with increased errors, reduced concentration, slower reaction times, impaired data processing. And this gets worse if you do consecutive night shifts in a row. So all of those impairments tend to increase the more nights in a row you do. And then after our night shifts, when we're heading home, we have higher rates of car crashes on the commute home. And so, all this to say is that humans were not designed to work shifts, and this comes at a real cost to us. And so if people want to have longevity in a career with shift work, we need to spend some time mitigating the impact of shift work on our health.
Absolutely. It's funny, I recently went to the sleep center to get my own sleep analyzed because I went through a period of time where it was really tough to get good quality sleep as I was flipping between days and night shifts. And so many of the typical strategies that they would employ just don't work for shift workers. And at the same time, EM is a 24/7 job. So we have to find ways to make this fit our lifestyles, or at least to mitigate some of those impacts. So in the sleep episode, Mike touched on some evidence-based scheduling principles that can help our teams achieve better sleep despite those shift work requirements. What do you think are the most important scheduling strategies to help our teams stay healthy, Sarah?
Okay. I have 5 big ideas about shift work and how we should schedule. Number 1, at the top of my list, ideally scheduling should be flexible so that people can match this both to their chronotype and to their life. And so a chronotype describes your sleep-wake preferences. This is the concept of some people are early birds and some people are night owls. And this impacts our ability to adapt to certain shifts. So night owls will prefer evening shifts, whereas early chronotypes will like those morning shifts and will have less circadian disruption, even if they're doing a very early morning shift. And when we have the capacity to align your shifts with your chronotype, it improves how well we sleep, it improves sleep quality and also sleep duration. And so if you're able to build a schedule where people can move into their preference, that's hugely valuable. And it's also really valuable to have that flexibility when people have external demands. Everybody has individual demands based on their family situation, their commute. And the more we can individualize, the healthier we can make this for people. So I know we still have to cover 24/7. I get that. But as much flexibility as possible helps improve how we adapt to shift work. So that's number 1. Idea number 2 is that we should use circadian scheduling or phase advancement. And this means that our shifts should rotate forwards, not backwards. If you're going backwards in time, that would be, today you work a day shift and tomorrow you work a night. Instead, we want to rotate forward with the clock, do a day, then an evening, then a night. These are easier for our circadian rhythm to adjust to and helps us again get better sleep quality. Idea number 3 is to schedule shorter shifts intentionally. So we know longer shifts are associated with higher risks of errors, higher rates of mental fatigue, and more negative consequences, both for ourselves and our patients. So in general, shorter shifts, and by that I mean 7 or 8 hour shifts, are associated with higher productivity and fewer errors. This also relates to that concept of casino shifts, which is used in some emergency departments across the world, really, because shorter shifts, particularly at night, can help speed recovery and how fast we can get back on a circadian schedule. Okay, that's idea number 3. Idea number 4 is we need adequate time off between shifts. We know specifically that when you have less than 11 hours off between your shifts, you get excessive sleepiness, workers can have insomnia, and the error rate goes up. So we need reasonable recovery between shifts. And if you're working multiple shifts in a row, you may need longer recovery periods to adequately recover so you can come back to work fresh. And my last thought about shift scheduling is really around equity and transparency. And this is just to say that I think successful groups incorporate fairness, transparency, and consistency around how they schedule, around their scheduling rules. And this should relate to how we schedule holidays, weekends, etc., because having that feeling of equity, knowing what the rules are, having those apply to everybody equally is really valuable for helping people feel they have agency in their schedule and that they're working in a place that values them as a person.
These are incredible and practical suggestions to implement. So for our schedulers and organizational leaders in the audience, you can help your teams to stay healthy and high performing if you build shift schedules with sleep preservation in mind. So just to recap Sarah's top 5 suggestions: flexibility to match chronotype preferences, circadian cycling, shorter shifts, 7 to 8 hours, or even less potentially, adequate time off between stacked shifts, ideally an 11 or 12-hour or more reset time between those days and night flips. And finally, scheduling rules that are both equitable and transparent to give your workers more of that sense of agency. I'm curious, Sarah, you mentioned re-chronotyping. How can someone identify what chronotype they are, what their preferences might be?
That's a good question. I think most of us know. I think you do enough shifts, Katie, and you're like, if you feel wide awake at midnight or not, right? You know when your normal bedtime is, you know how you would want to sleep and live when you were on holiday. And that gives you lots of clues as to your chronotype. I think people, after they've done a few years of shift work, or maybe even before they start residency, they might already know what their chronotype is.
At an individual level, we don't always have control over our own shift scheduling. And life does have a way of getting chaotic sometimes. So, Sarah, what are some of the biggest challenges you've faced when it comes to getting adequate sleep?
Well, and shift work, obviously, huge barrier. That's why we're talking about this. I'd say, although my biggest stretch, like years of challenge, was when my kids were young. There is no way to convince a toddler that mommy needs to sleep because she just worked overnight. Like, they don't understand that concept at all. So I think, those family demands, those things that happen in our lives outside work hours are actually where I've had my biggest challenges around getting enough sleep.
I've often told my friends with kids that it's so hard because it's like you've got a 24/7 hour job, but you don't ever get a post-call day.
Yes, right. Well, and when I think about, when you're working full-time emerge, that's a 24/7 job. And then kids, that's a second 24/7 job. And they don't always play well together.
We could all use some time turners in our life, I think.
Right? Absolutely.
So I'm really curious as well, what does your routine realistically look like then after, before, and between shifts to help you optimize your sleep despite those challenges?
I mean, I have a whole sleep routine, Katie. I have it, and I've worked on it over the years to figure out what works for me. So number 1, I have my room set up exactly the way I want it. I have a dark room. It's cool. I have amazing blinds that block all the light. I have a pillow I love. I have a white noise machine. I have eye shades. I have earplugs. Oh my God, earplugs took me years to get used to, but it was totally worth it. So my room is set up and I have invested time and money in that. I have pillowcases and sheets that I love because if I'm going to spend a third of my life there, then I want it optimized. And then I plan my sleep really intentionally depending on how I'm working. So for example, like if I'm going to do a night shift, I do like to nap before my night shifts. And so my whole day is planned in advance specifically to optimize that. So that morning, I'll get up early. I exercise hard in the morning. I eat on my regular schedule. I stop my caffeine early. I avoid any daylight or blue light for a couple hours before I want to nap. Like I have a whole system so that I can have that nap and walk into my shift feeling refreshed, even though that's not my normal sleep time. And I think just investing the time to develop those strategies or routines that work for you can be really, really valuable. It can take some time to work it out, and it will change as your life changes, right? My routine is much easier now that my kids are old enough to understand that they have to be quiet while I'm trying to sleep. But that investment in figuring out what you need pays off in the long run.
I love that. And I think I'm going to steal some of these ideas for like my gift wish list. But it sounds like we've got the physical investment in the space to make sure it's quiet, it's cool, it's calm, and you remove that external stimulus that's going to keep you awake and make it harder for you to catch that sleep that you so desperately need. And then the scheduling part of things. So planning ahead and looking ahead at your schedule and being very intentional about when you fit in your naps, how you're scheduling the other activities of your day. I want to pivot now to the second thing that you had brought up at the top of the podcast, which is that exercise and fitness piece. So many of us, I know, rack up impressive step counts on shift, but I'm curious if that's enough. And so, Sarah, how does your general physical conditioning off shift improve our overall on shift performance and general career longevity?
Yeah. So, I mean, exercise is so huge for us in terms of our health. I think everybody probably knows overall that exercise increases your lifespan, right? Not just the span of your career, but your actual life. So people who exercise have increased longevity up to 7 years more than people who don't exercise. This also has lower all-cause mortality, lower dementia risks in people who exercise. So there's that. But even more than that, on shift, there's data that exercise improves our cognitive performance. So we get better focus, attention, and memory when we exercise regularly. And it also helps us with our emotional regulation, which is huge in our jobs. So exercise helps us lower stress, which reduces our cortisol levels. It boosts our endorphins like serotonin and dopamine. We get better mood stability, better focus, and a longer fuse, which really pays off in our stressful job.
100%. And do you have any practical suggestions for incorporating exercise and fitness into some already jam-packed schedules?
Yeah, right. Everybody is so overscheduled. So start small. Start like really, really feasible. I think the people who try to overcommit at the beginning get overwhelmed. So start with something tiny. Maybe that's joining a gym. Maybe that's getting a trainer. Maybe that's signing up just for a fun activity you would like. If you do have kids who are involved in activities, this one took me a while. I don't know why I was so slow to twig to this, Katie, but I used to just sit on the sidelines during all of my kids' soccer practices. And then I finally realized that I could be going for a run during that time or stretching or doing, and starting to use that time for myself, not just for them, was a big shift for me because they were involved in a lot of activities, and reclaiming some of that time for my own health was really valuable. But I think the bottom line here is you need to decide that you're worth it. You need to decide that your fitness and health matters and just make this a priority in your life.
That is a brilliant suggestion. And I love the idea of starting small, just one step at a time, because I think we all see it January 1st. The gyms are packed with new people with resolutions for the year. And by February, that number has really thinned out. But I think that all or nothing thinking of, I've got to turn it around 110%, it's got to be a perfect, plan for my workout schedule before I can actually do this and maintain it, that often leads to failure or lack of success in adopting those habits. Whereas if we start small and just integrate those little things, those 5-10 minutes of some sort of activity while you're on the sidelines at your kids' games, that is such a brilliant idea of reclaiming that time and getting started.
Yeah, you remember those apps that had those 7-minute workouts on it? There are all that data that just 7 minutes a day can make a difference. We can all find 7 minutes.
I love that. And certainly at my shop, one of the things I started doing when we had our virtual grand rounds within our department, I would start to do those virtual rounds while I was on the treadmill, just walking or having a run. Or I know a lot of colleagues who got spin bikes and they would be spinning during those virtual meetings. And it's just a great way of integrating that into your regular day-to-day life. All right. So far we've talked about sleep strategies and we've talked about the exercise piece. I want to pivot to nutrition next. So Sarah, why does feeding our brain matter and how can we do it better?
Okay. So, your brain is a muscle. You need to feed it effectively. And this just has a huge impact on how we show up, how we think, how we focus. But the other interesting piece there is it relates to sleep as well, Katie. Like our eating patterns have a huge impact on our circadian rhythm. And so we want to be thoughtful about, if we can, eating on a regular schedule because it has a big impact on sleep quality. So getting thoughtful not only about what you're eating, but when you're eating is really important.
That is a great point. And I do want to dig into that deeper because I know certainly when I come back from a stressful night shift, I have no inhibitions and I am just like a little raccoon going through all of my cupboards trying to grab all of the snacks that I've stocked up over the week.
Right? Well, sleep deprivation makes us feel hungry when what we really need is sleep. Your body doesn't actually need food necessarily in that moment, but it's really easy for us to misread that signal or just get the signal that we're hungry. But we know, eating at night is terrible for us. It reduces our sleep quality, but this is also when our insulin resistance is the highest. So you're making your body and your pancreas work harder to cope with whatever food you're putting in. You're usually having sugar spikes and having the inflammation associated with that. So it is tricky, right? How we eat really does intersect with how we sleep.
So sometimes when you're feeling hungry, you really just need a nap.
Yes, or a glass of water.
And what are some other simple things that we can do to feed our brains and our bodies more intentionally?
So I think there are lots of different ideas here. Let me give you a few examples. Number one, on shift, you want to eat enough that you don't get hangry because no one likes a mean doctor. And so I think it is smart to bring a snack and some water with you to work. We also do need to hydrate. Your brain needs to be hydrated to work. We know this medically speaking, but it's true for doctors practicing. And so, yes, this does mean you will need to take a bathroom break during your shift. I know a scary number of people actually who try to not drink on shift so they don't have to use the bathroom, which I think is bananas. I think we need to normalize going the other way, like drinking enough that your kidneys are working should be a goal. And then you want to, I think, try to avoid the sugar spikes and crashes. This is a lot of the impact where we don't feel well. We know it's harder for our bodies to metabolize this. So I try to think about bringing a snack that has a low glycemic index. So this is, and when I think about this, I think about taking something unprocessed, something that doesn't have a barcode on it. So could you bring vegetables? Could you bring avocado, a little bit of fruit or some nuts or some cheese? Those lower glycemic index foods will help avoid those sugar spikes and crashes, and you'll be able to feed your brain while still feeling pretty good. And the other piece that played into it actually for me at work is a few years ago, we started this practice of intentionally giving everybody a break on shift when we had double coverage that allowed it. Obviously, this is trickier to do in single coverage places, but we normalized that everybody was just going to take a 15-minute break. Like, it's quick. It's not a long thing. But that means you can actually go and get real food out of your locker, right? It means you're no longer just eating the power bar that you had in your pocket, because the power bar is food. And yes, it has protein, but it's a very processed version of food. And some of those are just jammed with sugar. But when you start having that break, if that's an option for you, it means you can eat real food and improve your nutrition a little bit. And I found I felt so much better at the end of my shift when I have that opportunity to just have some actual nutrition somewhere in the middle.
I do think that sometimes when you are hangry or when your decision making starts to slow down, you don't always notice it in the moment. But I do notice that when I take that pause and have some water and actually eat some food, suddenly that decision making picks up. Decisions are easier to make, and I'm much more efficient when I'm doing the rest of my work.
Absolutely, right? I take that 10 or 15 minutes break, but then my productivity improves for the last 3 hours of my shift, and you get it back in efficiency. Like, I think this is worth it for our productivity rather than actually reducing how efficient we are.
I also think that sometimes, at least when I was starting out, I had this sense of guilt, especially when the waiting room was full and the beds were loaded, and I felt like I was that rate limiting step for patients being seen, and people had been waiting for such a long time to see someone, that there was that guilt involved in taking that bathroom break or taking that nutrition break. And it wasn't until a mentor changed my mindset and said, essentially, people can wait for 5 to 10 more minutes when they've been waiting for hours and hours to be seen. But more so than that, the 5 or 10 minutes that I take for that break to reset myself and recharge myself means that I'm going to be a better doctor for that patient. I'm going to make better decisions. I'm less likely to lead them astray or make the wrong call. And for me, that was a real wake-up call to start paying attention to my own needs on shift.
Exactly. And I bet if you asked patients, would you rather be seen 5 minutes earlier and have a distracted, hangry doctor who's mostly thinking about how much they have to pee? Or would you rather wait an extra 5 and have a focused, friendly, concentrating doctor? Like, I don't know. I know what I would choose.
All right. We've talked a lot about what we put into our body, and I actually want to take a moment to specifically touch on caffeine, because I think that's a really pivotal part of what we utilize on shift to keep ourselves awake, to keep ourselves perky. How can we be more intentional about our caffeine intake pre, during, and post shift?
Oh my gosh. Okay. Well, I'm going to give you my opinion here, Katie, but can I just state my disclosure up front is that my caffeine addiction is real and serious, and I love my caffeine, and I'm not sure I could give it up. So, but I do think you want to think about it. If you're drinking so much caffeine that you're having serious withdrawal and headaches, maybe you want to switch to half caff. You want to time it right so that it's not impacting your sleep, and be thoughtful about when you're stopping caffeine if you're planning on going home and sleeping right after your shift. But there are studies that show that caffeine helps us increase concentration and focus. It can help us pay attention. And so I think, am I just self-justifying? I don't know. But I do think there's an argument to be made that some caffeine might help us, particularly on shifts that are not well matched to your chronotype. So if you're working a shift where you normally would feel drowsy, this can help us with alertness. I do know some experts who really advocate for matcha, which provides that mental boost as well, but is thought to have sort of a smoother impact on focus and concentration without a crash that people can have after caffeine. So that's also an option for people to try and consider. But I don't know. Don't tell me I have to quit my caffeine, Katie. I couldn't do it.
I would never make such a claim. As a matcha latte lover, I can say that that's very bolstering evidence. So I like that. Do you tend to cut down your caffeine or stop your caffeine intake a certain number of hours before you're planning to sleep? Are you intentional about that, or is it more about the shift itself and what you need for alertness?
I do pay attention to it now. I will say when I was younger, I feel like I could drink unlimited caffeine and then still sleep well. So if you're still in that phase of life, I encourage you to really enjoy that and lean into it because I miss those days. I am now sadly old enough that I'm in the menopause insomnia years, and I imagine I'm not alone. Some of our listeners are there with me. And I do find now that caffeine has more of an impact on my sleep quality and my sleep duration. So I do try to stop. I mean, ideally, I would stop 5 or 6 hours before I slept, but I rarely pull that off. And there is a lot of individual variation on how we're impacted by caffeine. So it's important to just think about what works for you and pay attention and adjust accordingly.
Yeah, as with any other suggestions or measures that we take, there's such an individual level of variation in how we respond to those things. And just as an extension of, what we should cut back on or be cautious about, is there anything else nutritionally that we should be avoiding or potentially cutting down on for health?
The other one that I think we want to be thoughtful about that does sometimes come up in emergency medicine is the concept of using alcohol as a sleep aid. This is I would say, not uncommon thing of people wanting to go home after shift and needing a way to unwind and leaning into alcohol as an option for that. But we know that alcohol reduces our REM sleep, reduces our sleep quality. So while it may help you fall asleep faster, you might not get the sleep quality you were hoping for. And I think we want to be obviously really careful when we're using alcohol or any other substances to help us fall asleep because the addictive potential is real.
Yeah, and I would say for just more content on nutrition tips specifically for shift workers, listeners can also check out Dr. Melody Ng's segment on EM Quick Hits episode 62, which covers more of the physiology behind digestion, nutrition, and endocrine disruption in shift work. I also think it's important to acknowledge that individual strategies can only go so far. At a certain point, we also need to have system-level support from our leadership teams to be successful. So, Sarah, what are some effective things that can be done at a leadership or organizational level to improve life on the EM front lines from a physical wellness perspective?
Okay, and Katie, can I just say, I am really happy we're talking about this piece because for a long time, there's been this vibe that our wellness is just on us and we have to do all these things as individuals. And I think that's not accurate. I think if we really want to get healthy, we need system fixes as well as personal investment in ourselves. And so, yeah, there are easy things your department or hospital can do to help you with your physical wellness. Like, number one, staff should have easy access to drinking water. You should be able to get a water easily on shift or in your office or mailroom. And it shouldn't, maybe that's giant water bottles. Maybe it's whatever other version of water you prefer. But that's easy and seems so simple. You should have, I think, a fridge with healthy snacks where staff can get snacks. We instituted this a few years ago in my place. We were putting in all of these wellness initiatives. This was actually just before COVID. And one of the things we put in was we stocked the fridge with healthy snacks. This has been the most popular thing we ever did. Of like the 50 wellness things we tried, this was the winner. And we just have a standing grocery order. It arrives every other week. One of the admins just receives it from the person who brings it and pops it in the fridge. And it's just there. We pay for it out of the operating budget. But it means you can actually have healthy food. You can have an apple or cheese and crackers or a handful of nuts, something good for you rather than what you would otherwise get out of the vending machine. And I think this is particularly important in hospitals that don't have 24/7 food access for staff, that you need to give people a healthy snack. In terms of sleep, I think staff should have access to a sleep room where they can crash after a night or before they have to do a long drive. And so I think hospitals should have rooms where staff can sleep, and these should be available to anybody, and we should make use of that. And last but not least, I'm going to take us back to scheduling. I think we should invest in shift software that works for your group. I think whoever is doing the schedule should get a stipend for their hard work, because you want them to invest in making that schedule work for everybody. And that is valuable. We should put money on that to make sure it happens in the healthiest way possible.
There you have it, folks. Some practical pearls on meeting our physiologic needs for sleep, exercise, and nutrition from Dr. Sarah Gray. There are so many things outside of our control when it comes to this line of work. It is well worth taking a look at the parts that we can control and prioritizing them so that we can perform at our best, not only for the patients and teammates who rely on us, but also for ourselves and the people in our lives who care about us. Remember, when it comes to sleep, shift scheduling should follow circadian cycles, ideally shifting gradually forward and building in enough recovery time between day and night flips to reset the sleep clock. Prioritizing strategic sleep in your schedule and protecting that time like your life depends on it is so important, because it literally does in the long run. Exercise makes us healthier, stronger, smarter, and more emotionally regulated. Don't leave it to chance. Start small if you must, but start somewhere and let go of that all or nothing thinking. It's not about the lofty New Year's resolutions or the fitness plan overhauls, but rather any small step forward that you can take today, which creates meaningful progress that compounds over time. What you feed your brain matters. Your mind can't perform optimally if you neglect to fuel it with purpose. This includes what you put into your body, what you avoid putting into your body, and both the physical and intellectual content that you feed yourself on a daily basis. And start small and snowball. Don't aim for perfect, aim for better and doable, even if it's a bit messy and suboptimal at first. 1% better per day leads to a compounded effect of almost 40 times better a year from now. Sarah, any final words of wisdom to add for our audience?
Well, I guess I would just circle back to that feeling of feeling guilty when you take that 5 minutes for yourself, because I do think in our med school and residency programming, we are almost taught that it's selfish to take that time for ourselves. And that's where that guilt pops up. But we need to unlearn those bad habits if we want to increase our wellness. We can only show up as our best for our patients if we are healthy and strong ourselves. And so devoting those few minutes to yourself actually results in long-term wins for the people you are looking after. And so taking care of yourself is not selfish. It is a required part of your job, and we should make space for that.
Thank you for that reminder, Sarah. And that brings us to the end of part 1 for our Coaching the EM Mind series. I'll catch you next time on part 2, where we tackle the topic of stress management and safety on shift. As we wrap up, here's my challenge to you. What is the one thing you're going to do differently to keep yourself physically healthy on your next shift? Thanks for listening, and remember, you are what you practice, so make it count.
That was just amazing. Thank you so much, Sarah and Katie. If you like what you hear on EM Cases, please do consider a donation. Just go to the EM Cases website and hit the tab there, donation. And just to let you know, Katie and I will both be at North York General's Emergency Medicine Update Conference, better known as EMU, in Toronto in April. There is still time to register for that, so hopefully we will see you there. In other conference news, the EM Cases Summit in November is coming along very nicely with our planning. We have pretty much the full speaker schedule set up. We've added a few pre-courses. Katie's going to be doing her Synapse course. We've got Aaron C.L. doing an orthoradiology course. We've got Jesse McLaren doing a Hearts ECG course. And we've got all kinds of symposium, including AI symposiums, rural emergency medicine symposium, ED flow symposiums. It's going to be a fantastic summit. I hope to see you all there at the International Virtual EM Cases Summit in November. Just go to emcasessummit.com for more information. Until next time, take it easy.